Good evening. So, this is a story of about 2,200 sleeps. One you may actually know. Now, I want you to picture a child you've seen. Crowded arches, dark circles, mouth open at rest. Maybe while playing video games, maybe when reading, labeled behaviorable, or possibly has an IEP. Poor sleeper in history, all the things that really come to play in the social and early childhood history. Poor breastfeeder, colicky, all the things. Now, here's the uncomfortable question. How many of those were early signs in the years visibly before? Maybe if that child was 7. How many were simply not screened for? And that's what makes the age 1 visit more powerful than we know. Most pediatric airway problems are identified between about the ages of 5 to 8, not when they begin. And usually our children, as you may know, are in mixed dentition. When it reveals the structure, they may have palatal constriction. It becomes more measurable. Crowding becomes visible. Mouth breathing becomes established. Behavior really starts to show. But that recognition age is not that onset age. And in many cases, it happened much before, and those functional risk signs were there. So the question is again, why don't we screen any earlier? The critical growth window is really from 0 to 3 years of age. And that's because the airway story doesn't start at 7. It starts with the most rapid years of growth, which are 0 to 3. During that window, anatomy is not fixed, it's programmed. As you can see, behavioral patterns become habits, muscle patterns become habits, tongue patterns become habits. All the habits are setting their foundational growth, but they can change. So when a child repeatedly becomes what we call structurally out of growth cycle, it's not in the orthodontics yet. It's a biology issue, and intervention actually can happen. So I'm curious. First question. Do you screen for airway in children under 3? Here is where the awareness gap begins. And it's not even with those that are in this seminar today. 69% of families don't know that age 1 is the first dental visit. And I don't know if you know this, but this recommendation by the American Academy of Pediatrics has been out for 25 years. In 2001, the recommendation was made. So as we know, sometimes that means families wait. And while they wait, growth keeps happening. And when we look at that most common dental visit being age 3, and you think about the slides before, when by age 3, the swallow pattern is set, the breathing pattern is set, the tongue posture is usually set. And although we didn't miss potentially the cavity window, we did miss the development window. And so when we look at repeated function, it shapes anatomy. By the time they've gotten to age 3, kids have been doing their breathing, their tongue posture, their muscle function for over 10,000 times. It's impressive. And for a child that sleeps about 10 hours, that's over 3,600 hours per year of sleep. So that function that's repeated over and over that may initially have seemed small now creates a big structure. Nasal breathing widens the arches, oral breathing narrows them. Good sleep organizes the brain. Fragmented sleep stresses out the brain. Anatomy is the record of repeated behavior. And so now our kids are age 7, and that dilemma begins. And again, why age 7? Well, the American Academy of Orthodontics recommends the first orthodontic screening at age 7. And that's really when the structure finally just peels back the layers and exposes itself. And now that crowding becomes measurable, mouth breathing is established, behavior is certainly at least cemented and maybe even documented. But of course, as we said before, that's not when it began. That's just when that evidence became undeniable. So by 7, when we see those crowded arches and dark circles, we see the airway child. But we see the origin of that at infancy. Snoring didn't just stop. The body adapted for years before we recognized it and really tried to conform to what it was thought was supposed to be normal, but really wasn't. And so that diagnosis at age 7 is really just documentation. It's not prevention at that point. It began here. And for my dental colleagues, do you remember these diagrams? Well, this is where it began. The story actually began before birth. The airway, the craniofacial structures are adapting in utero. The palate, as you can see, the nasal cavity, the tongue space, all developing together and early on. So when we evaluate breathing, we're actually evaluating growth, not just teeth. Here again is where the palate is developing. We see our arches, we see the nasal septum, and there's even influence at that early age of what's going on. One more slide just to cement it in a bit, because that all translates to this child, this human being that is now getting ready to be born and ready for whatever other adaptations it's making. So we're talking about growth and development, all in that when teeth are developing at 6 weeks of age. And so birth happens, right? And we start these interesting little adaptations. Children don't fail to grow, they adapt to grow. So if the airway is constricted, the body compensates. The head leans forward, the open mouth posture happens, the altered swallow. Adaptation is what keeps us alive. It reshapes the anatomy. And so when we have that disruption, you'll find that about disruption or those adaptations lead to the disruption. We see those behavioral issues. Look at the stats. 15 to 70% of children who have ADHD have sleep issues. Up to a third of them have sleep disordered breathing. And sometimes that behavior then is not behaviorable. It's literally neurological fatigue. I like that statement only because it's very impactful. Think about it right now. At some of us on East Coast time, where it's 8, almost 9 o'clock, we're probably in this state of potential neurological fatigue. The brain can't regulate, and therefore it can't rest. Behavior becomes the sleep signal. Another adaptation that leads to disruption is mouth breathing and its effect. When the palate narrows, crowding worsens, sleeping worsens, food issues appear, mood changes, all those things are where those adaptations that we thought may have been a little bit normal or may have been terrible twos or just a part of growth and development are now showing themselves. And orthodontics is then appearing at that age 7 that we were talking about. Last symptom, though, not the first. When we look overall, the foundation of what we have is being developed. And so when we talk about long-term issues, that narrow palate leading to posterior crossbites, resulting in more complex orthodontic issues, leading to more crowding, leading to even more complex issues. One more point to drive forward in that adaptation to disruption, that sleep disordered breathing that we were talking about, manifesting as snoring, or for a child, heavy breathing, bruxism, grinding, the things that I learned, particularly in residency, that happen. They just happen sometimes for kids and they'll grow out of them. We're recognizing that that's not the case. Food and mood. So sometimes Krabby Patties or kids that are hangry have a terrible mood about themselves. And this is all related to sleep, early disruption, not being able to breathe properly. All those developmental outcomes come to a peak. And so with that, I've laid the foundation, and pretty quickly, I may say. But what I say is, this is why we're going to talk about for the next 30-ish, 40 minutes about setting that foundation of the age 1 visit. The age 1 advantage is what I like to call it. It's not about teeth. It's honestly a developmental checkpoint. We're evaluating how a kid feeds, breathes, sleeps, and grows. The timing, though. This is the early dental visit. We all kind of know about this part. And kudos to that, right? We've established through the American Academy of Pediatric Dentistry in 2001 that something earlier needed to be done, mostly because dental cavities is the number one most common chronic disease of childhood, still is. But we know that by these early dental visits, at least we can prevent earlier and we can reduce the risk, the burden to families, and everything else that goes on during that early period when it was 0 to 3 and our kids were showing in at 3. And so when we're looking at other things in this early dental visit, we're usually looking at hygiene practices, of course, maybe some feeding, but we're not as much talking about that other foundation of sleep and airway. We know that if we start talking about these things and looking at not just a component of the teeth, but feeding, speech, breathing, airway, control, regulation, it supports a few things in our growth and development, like well-rounded developing child and promoting social and emotional development, encouraging kind of lifelong curiosity. And that's in terms of piquing themselves and seeing themselves in a medical setting more often and with adults who are providing that care. Addressing diverse needs. We may actually be able to identify some growth and development issues earlier and help families get the care and support they need. And improving those long-term outcomes, not only dental-wise, but overall health-wise. We're literally evaluating systems because parents think we're checking teeth, but dentistry becomes the first place, and it can be the first place where a child's growth story is actually interpreted and then helped in a team setting. So now look at the whole child: social, emotional, cognitive, physical. That means when we add teeth, we change the way this looks forever. Teeth are not the center, they're the indicator. They tell us how breathing happened. They tell us how sleep happened. They tell us what they ate. They also are visible evidence of the physiology that's happening. So let me ask again, my second question. Which symptom do you most associate with pediatric airway issues? Curious. Okay, I think I've given some time. This is good. The results just dropped, but I think the most common answer was mouth breathing. And interestingly, by our data and other polls that we've taken, that is not usually the answer. Most clinicians will choose snoring, but honestly, snoring is late. Mouth breathing is earlier, which is great. So kudos. Mouth breathing is usually earlier. Poor sleep is usually earlier. Feeding difficulty is usually earlier. The earlier the symptom, honestly, the more prevention is still possible. So that means if we're tagging that on much earlier, then we have a better chance of making those habit corrections later in life and earlier in the visits that we see them. So this is great. This lands us on what we want to talk about now is the traditional visit. But after today's conversation, it's no longer going to be a traditional visit. But I know this is what we may be used to, right? The traditional age 1 visit, lap to lap or knee to knee exam, fluoride varnish maybe, nutritional counseling, all important, but not necessarily complete. And that's because disease prevention is not the same as development screening. And so you see, this is what I'm used to all day, every day, lap to lap procedure. This is the cornerstone of our first dental visit, and maybe even up to age 3 or 4. My son was 4 when we were doing still knee to knees. So, but this is what we see. And the benefit of that is it allows the dyad to still be in place. It still allows some emotional and physical comfort from the parent, and you're able to see a little bit better. In the functional exam, though, it becomes a little different. And that traditional exam usually will answer one question: is disease present today? It's a snapshot. And that snapshot may miss patterns that we're developing. And so in this functional dental exam that I'm presenting to you, we're assessing oral form and function along with the other dental developmental characteristics that we have. And so we look at it a different way. What risks are we forming? We evaluate breathing, feeding mechanics, oral posture, movement. It's no longer dentistry reacting. It's really dentistry forecasting. And so those two types of exams where traditionally we were looking at, okay, what disease is happening within the mouth, maybe within the tissues, the gums, etc. But from that airway functional exam, we're looking at what other developmental concerns can I help with, right? One protects the tooth, the other protects the child. I hope you see where I'm going in this. So when we're looking at this traditional dental exam, I put 4 bullets there under there. Granted, this day and age and where we're headed, I know there are a few more, but I just wanted to kind of be a little dramatic when I went from the traditional dental exam to then when we look at our airway-focused functional exam. You can see all the other things that are included in there, and that's what each exam may look like. A diagnosis. One diagnosis. One helps find direction. One finds damage. One helps to move in the direction of growth and development. So that one question that can change everything when we ask, are the teeth healthy today? Or in a whole child question, will this child develop health problems later? That's where the functional screening starts to change lifelong outcomes. And I know it was going to come up. Well, how much time is this going to take, Doc? I'm asking for 2 minutes. Honestly, an age 1 visit, that may be all you have. And so that doesn't require a new appointment exactly. If we want to dig deeper within my practice, we do another appointment. But in this appointment, take the 2 minutes, observe the lips, observe the breathing, look at the tongue posture, ask about sleep, ask about feeding. 2 minutes that can change 7 years. The timing difference when problems are usually found, where cavities are usually found between 3 to 6 years of age, crowding is usually identified around 7 to 9 years of age in mixed dentition, sleep issues between 6 to 10, behavioral concerns between 6 and 10. Now we are on to something different. We're treating those late symptoms in this timing difference. We can treat early signals. It becomes beyond cavities, where we look at functional patterns in the trajectory of our growth and development, because those cavity exams may truly miss those functional patterns if we aren't asking. And that's what's driving the overall structural outcome, growth-determined orthodontics. One of the ways that we screen is through a few things. There are a few ways we screen, and there are a few different types of screening ways that we can use, but the easiest one that I like to use is called the Ferris 6, because then I can look overall at certain things, and there's a Ferris 6+10 or 6+4, which adds a few more red flag indicators. As you can see, this one that I have on the screen is one that's just a little bit more mature, because you're looking at some signs of, in 5 and 6, you're looking at tooth signs of wear and things of that sort. But really what I wanted to hit home is there are easy ways of doing quick indicator screenings. And again, when we have those indicator screenings, then we can dive a little deeper. In our Journal of Pediatric Dentistry in 2021, it was asked to add something of this sort, a screening, sleep, and airway indicator to your dental visits. I hope that at this time we're getting there. But again, when it took 25 years to really get to potentially an age 1 dental visit, I know that this is going to take some more time. That's why I'm here tonight. because I know that shifts can happen. And when these shifts happen, when we have shifts in the impact of breathing patterns when it's not being done correctly, we know that altered forms can happen. Low tongue posture can lead to additional bacteria and germs in the mouth. Mouth breathing can lead to altered tongue posture, which has an improper makes an improper palate form. And those shifts can then change the entire growth and body development. The early intervention is now when we have reduced mouth breathing, we actually enhancing our overall oral health. We know that. We know the benefits of enhanced and reduced mouth breathing and decreased snoring. Because when we have that, we have better sleep quality. And we know that those health outcomes lead to other things that are greater for our patients. Now, we just have to bring that into our office as a part of our visit. Because when those delays happen, we know that those effects really hold on to long-term issues that then not only again affect the teeth, but go down to our heart, our lungs, and our overall life trajectory in terms of years of life. When we start having those pediatric associations on sleep disorder breathing and mood and attention, then we start thinking about if we got 2,200 better nights of sleep, what more would we be capable of? What more would our kids be capable of? 2,200 opportunities for growth. When they go right, we can change lots of variables. When they go wrong, we can really deter what a child is capable of. So the shift happens, and it happens now. Because when we start talking about transforming pediatric dental care, we're looking at those developmental checkpoints and those long-term impacts, and to be honest, saying no more. That it stops here with what we can do. We no longer look at a dental milestone. We look at dentistry moves from repair to overall guidance for our families. And we just insert ourselves in there. So no single provider does this alone, right? And I've recognized that and really surrounded myself with a group of providers that are on the same wavelength, not in competition, but understanding that we all bring a different viewpoint to our child. And so when we become a part of that, we actually are one of the ones who initially help that guide because sometimes we see those kids more often than anyone else in this group does on this page. And so when we start now and looking at early child intervention, then what we do is we look at that reactive care and make it proactive screening. That reactive care at age 7 now becomes proactive care at age 1 and gives that kid the advantage. Same child, different future. And our call to action is really when we look at the early airway screening, we can then do a few things. We get first access, we prevent complications, and then together we're looking at long-term plans, right? So many of us that start out as pediatric dentists, we sort of send them on, right, at a certain point to our general providers to create the rest of their long-term plan. So for us, I still think of it as that age 1 visit, not as just a short-term plan, but a short-term to a long-term outcome. That's what I like to think of it as. Because those early screenings, when they change the outcomes, then we present a patient to the general dentist that's now sleeping better, that's now potentially has better oral health, that is breathing better, that has less comorbidities. And we are looking at that to prevent those long-term complications. So that call to action that we make continues. Sorry, let me go back one more. That call to action that we make continues through our early intervention, through our maternal screening, then to that age 1 visit, then through our teen tween years where we change a little bit of how we screen because we're screening for a few other items in care, and then moving into that adulthood screening. When you talk to families, and even when you talk to colleagues, I wanted to put some statistics there that really help to cement what we're truly talking about, right? Because it can seem just a little bit out of sorts or really just kind of wishful thinking in terms of how this can happen. So when we look at how common pediatric sleep disordered breathing is, it affects 2 to 5% of children. But the symptom-based disordered breathing, which is more common, that's the snoring, or now you know, audible breathing, affects about 4 to 11%. So in a practicing about 2,000 active pediatric patients, there are 80 to 200 plus children that may have airway sleep issues. When you see that next child, I wonder if you're going to think, are they one of the ones? And if you're thinking that, you're way ahead. But now we know that we can do something more than that. When we look at the long-term health impact of untreated pediatric OSA, 3 times higher odds of hypertension. Now we know all the effects of that, even orally. Increased risk of cardiovascular and metabolic dysfunction, associations with behavioral dysregulation and ADHD-like symptoms, which we talked about earlier, and impaired growth and inflammatory burden. Now, for me, I have to put my master's in public health hat on and think, what in the world does this look like in disease and health? What are the social determinants that affect this child if not determined and discovered and allowed to go throughout life like this? The social and neurological behavior outcomes, again, poor academic performance, executive function impairment, behavioral challenges. What does this child then look like as an adult? And the cost of not screening. And this was honestly, this number, every time I see it, just blows my mind. I'll really be honest with you. Because what we're looking at overall is 226% higher healthcare utilization. Think of that in dollars, right? Think of that in the burden to the healthcare system and the burden to families. It means more ER visits, more prescriptions, more hospital days, healthcare costs increase with severity and younger age. Keep that number in mind. 226% higher healthcare utilization. That number, again, every time I see it, blows my mind. So when we look at intervention and translate that to real life, when we look at a tonsillectomy, adenoidectomy for mild sleep order breathing happening, a 32% reduction in healthcare encounters and a 48% reduction in prescriptions. So 1/3 reduction in annual healthcare costs post-treatment. That all translates to early intervention works. But I think those numbers and really just kind of thinking of it in that way really helped me to understand the impact that I can have on overall just family intervention and education. And again, what we're looking at is not exactly as if we have to be able to treat it all, but we can recognize what's going on and go back to that teen and say, hey, ENT, pediatrician, something is not right. So another question, curious as to how many of you were aware of untreated OSA increasing the healthcare utilization about 226%. Okay, so it seems like me, previously, many of us weren't aware of the actual burden on the system of untreated pediatric obstructive sleep apnea. But it's a real and true thing of what we can again help to move forward. So let's talk about implementation and strategy because we don't have a whole lot of time tonight. And we could dig deeper into this. And I look forward to the questions that you have about any of the things I've been talking about this evening. But it really comes down to how we make that approach, right? Because I've asked you for a few things. I've asked you for 2 minutes, maybe a little bit of extra time, maybe just some time when you're talking to the family. I've asked you to do some additional screening and maybe even form and meet some new friends in terms of colleagues. When we talk about implementation strategy, we're really looking at team training. And for me, in putting this within our offices, this was a big thing because it learning more about this took me back to residency almost, right? And so I had to teach that to my team, and we went to different conferences and, but inside the office is where the learning happens. And so that comprehensive staff education on these models, and they are sometimes complex models, right? We are making associations from age 1 to age 51, right? And parents ask us literally in the whole timeline. We also have to know and look at what family education means, simplified. Because when I was first talking about airway and sleep and how that related to dentistry, and then I was talking about, well, also don't eat fruit snacks, families were like, what is happening here? Like all over the place. And honestly, the conversation would veer many different ways. And so I really had to work on my clear communication about what I can do and what families can expect. The medical coordination part in this implementation strategy, this is the part that keeps me up sending emails at midnight because that collaboration, we aren't in dentistry, many of us in private practice aren't in a EMR that actually flows together where I can log in and see all the specialty cares and see everything that's happening. So I have to reach out. Our team has to reach out and say, hey, can we get this documentation? Or hey, can we get this email? Oh, got it. Can we send permission? Can you send the permission for this information to be submitted? And then can you go into the portal and submit? It is that medical coordination, it takes time. And thankfully, we've built a system where the expectation now is they know we're coming. They know we're coming with an ask. And the barriers are much lower than they were when we were just starting out with implementing this functional exam. And then outcome tracking. So for us, that means we're constantly keeping notes and keeping data and letting the team know like where we're at. And then each year, and this year I may actually do it twice a year, we do like a state of our patients. State of our families is what I call it. And that really shows from the questionnaires like the Ferris 6 and the Ferris 6+4 that I showed you of what's happening within our practice because many parents they don't exactly know, right? And they think, well, just because it's common means that it's okay. And there are a lot of misnomers. And so when we talk about the state of our families, it also brings the barrier down a little bit to open that conversation because then no one is exactly in a closet about what's going on. They're really just, they're saying, hey, there are other families that are struggling with like me. And sometimes they ask to be connected with families who have successfully gone through this process and actually changed things about what's happening. So these are what we look at. Team training, key, right? You see it as number one. Family education, medical collaboration, outcome tracking, all important in that implementation strategy. And then we look at that proactive instead of reactive screening model, right? Not just drilling and filling, not just identifying cavities. We're looking early. We're looking at those signs, identifying potential issues, and then going and taking that to the family and creating our interdisciplinary collaboration amongst our providers. And that just doesn't mean, healthcare providers. Sometimes that means any of our external providers who may be providing holistic care to those families. And so you saw the big list of people around me that we surround ourselves with. There's probably more that I don't have on that sheet again. And I always love with our children when like their grandparents come with them or, other extended family members, because then I'm just documenting and really getting a sense of what's going on in the family. And usually you can see it. You can see where this child gets this all from because it's apparent and showing in front of you through the history that's sitting in front of you. We look at growth guidance, habit correction, because we're looking at those long-term habits. Again, not all habits are because a kid wants to. Some of those habits is because they have no other choice, meaning they are posturing themselves to be in this position so that they can breathe better. They're posturing themselves so they can go to sleep. They don't want to be picky eaters, but that's how they feel. That's the soft foods are the best things that go down, and everything else feels like they're gagging or choking. All of those things we put into growth guidance, habit correction, and then preventive healthcare in that proactive approach. And this is on screen, elevating what we do every day. And so we take this child at 1 year, right? And we look at airway, feeding, speech, oral hygiene, and really put it together for them. We have our colleagues in specialties and specialists. We don't forget about our pediatricians. And we make our referrals and suggestions where necessary. Again, not always having to treat, although I have a whole armamentarium of growth and development oral appliances in my toolkit that I like to use and pull out anytime I need to. But also in the practice that we're in my practice, I have a myofunctional therapist in-house. So some of these things we've already developed. And in our interdisciplinary care center, we have feeding speech. So there are a lot of things that are at our fingertips. But honestly, that elevation came out of frustration because I was tired of identifying something and then having to wait 9 months to actually find out if that was the issue, etc. Right? So now I'm still on time. I didn't think I was still going to be on time. As we look at this picture, we looked at this picture in the beginning, right? But as we look at this picture again, and we think about the child's 0 to 7, but let's just say 7 again, because they're maybe in our chair getting their first orthodontic exam. Well, that child at age 7 is the history of that child at 1. They're wearing the history. We just met them later. But when you look at this picture, if we screened earlier, we actually have the opportunity to change the story. Because every kid will sleep just about 2,200 nights between the age of 1 and 7. Where we are, and honestly, what we can decide tonight is, are we going to be a part of this story early or only called when this story is already written? You see this child in the middle? This picture was taken at age 1. And in my own life, I have proof that this approach from age 1 early on is the advantage of what I see right now. This kid, my son Nicholas, at age 10. When we look, if you're ever searching for additional guidance, you have our American Academy of Pediatric Dental Guidelines, which help you make some decisions about where and what to do. Talks a little bit about those early dental visits and what other things you can include. And in my last question, I am very curious now, after today, will you incorporate some sort of airway screening in your everyday practice? I'm only accepting one answer. I am with you. I'm enjoying the now as you all are answering, I'm enjoying the comments on the side. I totally agree. There's work to do, Richard. Let's talk about it. There's work to do. For all of you that may be thinking about this implementation, create a little guide for you. Simple questions, right? But it's sort of the things that I think about in growth and development through my eyes, and reminding us that it's so much more than baby teeth and something for you to start, just to start, right? Because so many of you, 84% of you said you're ready to start immediately. So I'm using myself as a resource and this mini guide as a resource for getting that immediate start going. I look forward to seeing where all of you are going on this journey if you haven't already started. And please keep in touch with me. You can scan and get all my information, the complete download on this QRS. But let's keep in touch. This conversation is one that's dear to my heart. As you can see, it's very personal, but also that age one advantage is huge. And I think we have an opportunity as dentists to make something happen differently for our kids. Thank you. Okay. I can see them. Okay, so what airway findings do you find in a 1-year-old, and what can we and parents do to act early to prevent future problems? Also, is mouth breathing normal at a very young age? Great question. So, some of the airway findings that you may find initially, um, two that stand out are things like low tongue posture that may be from oral restriction. And I know that um, lip and tongue ties sometimes are getting a dirty rap, but there's a reason to pay attention. There's a need to pay attention to them. There not may not always be a need to intervene, but there's a need to pay attention to them and how the tongue and mouth are functioning. And so things like audible breathing, open mouth posture. My little kids, because of their overall development, are going to have sometimes it's less control, like oral muscle control than actual mouth breathing. But those are the things, that's why we start asking the questions, because low tone could mean something else also. And so to answer your two questions, one could be mouth breathing, one could be audible breathing, and those are things that would at least make you ask questions. And then mouth breathing at a very young age, there will be some, but again, you want to pay attention to it because it could mean something else, like low tone, rather than just mouth breathing because of the posture of the mouth. That was a long answer to that question. One more question. We're talking about bruxism at a young age. So there are various reasons why kids will grind. And so the answer that I'd learned 20 years ago was just this is something they do. And the reasons start from something they do potentially because new teeth are coming in, which is possible. Something they do neurological or maybe a neurological issue. So you may find that children with special challenges may grind more. Sleep habits, sleep hygiene, and then, of course, airway posturing, because what bruxism does, and grinding, as I explain or call it and explain to my parents, it's like snoring. It's like literally if you have like a lawnmower, one of the ones that you have to pull to crank, that's what the body is doing when you grind and when you snore. It's literally wrecking the body and shaking and go, hey, you wake up. And so at a young age, I very much so still something to pay attention to. And you have to pay attention to the patterns. Is it just when they have a cold? Okay, well, that coincides. They can't really breathe. They're struggling a little bit. Or is it nightly that you're hearing this bruxism? Um, any input on how ENT responds to our referrals? Sometimes they don't want to take out tonsils. Ooh, yes. I actually had a conversation about that today. Um, My ENT colleagues, they come, their perspectives are interesting for a few reasons. And what I do when my ENTs don't want to take out the tonsils, I ask them basically for permission to do some initial prevention. That may be expansion, that may be night appliances. Um, it could run a gamut of like, how can I open up the airway? We always start with like nasal clearing, and then we may be talking about allergies, and we kind of just go the whole gamut around them to then say, we've done it all. There is nothing else we can do. Have the tonsils shrunk because of this? Nope, haven't changed. Okay, we need to do something else. Now, one of the things I didn't mention in overall prevention and care, and knowledge is the sleep study, because that is like the gold standard for if we're looking at obstruction and things of that sort. The issue with that is a sleep study is pretty expensive. Both of my kids have had sleep studies, and one of the bills I actually took a picture of because it was $10,000 for an overnight study. And so, as much as I'd love to be like, go take a sleep study, go take a sleep study, sometimes it's not possible. Um, in our area, there's one children's hospital that does it, and maybe a couple of other sleep centers, but not particularly for kids. And we've tried, which, they don't work very well for kids, the home studies just to get on a basis of what's going on. I can usually use my home study um, barometer for kids maybe 6 and up, but the sleep study is where it's at. So I asked the ENT, sometimes I'll say, well, if you don't want to do this now, okay, let's do the nasal hygiene. Let's do allergy testing. Let's, make sure dust, dander, they're cleaning their stuffies, they're not sleeping over vents, all those things. Like, let's rule all the things out. Give them a little bit of time, not long, a little bit of time. I say like 6 months because that's a long time in a young child's life. And then if we can't, we've got to do something. Next question. After recognizing sleep disordered breathing, is there anything we can do at dentists other than advising parents to bring to PCP for further evaluation, referring to ortho for phase 1 treatment at an appropriate age? What treatments are done to prevent sleep disordered breathing on the medical side for our own reference? I may have answered some of that in the beginning or just now in terms of the next step for in the pediatric realm and even in the adult realm is potentially appliance work and really opening up the airway and allowing better breathing to happen. Because we know if they can breathe better, then they can sleep better. And we know that the obstruction is coming from potentially something in the head and neck, especially if it's not happening, if something else is not happening within the rest of the body. So yes, ortho referring to phase 1, some of those things we can do, or my orthodontist, my orthodontist on my team is like gung ho, like, let's go. And again, not just for teeth, we may be doing it just for airway. And sometimes those are conversations that even if I'm referring to another orthodontist, we have like, okay, why are we referring? And what is our end goal? And so I enjoy working with my orthodontic colleagues. And again, if they're very young, because like I expanded my 3-year-old, almost 4-year-old. And again, not with rapid palatal expansion, but we were just kind of early shaping of the oral cavity. That's really helping to address some of those issues, especially in high and narrow palates and things of that sort. And so when we look at what else we can do, the next step is potentially overall care, and appliance work. That again, like I said, it was an all-out residency for me. There are lots of appliances, there are lots of options, there are so many different ways that this can be approached. So the next step, when you're recognizing, is to form your team, form your group, have your colleagues of those that are talking about this on a daily basis and really looking at options. Um, on the medical side, I would say some of the treatments that are done besides, taking out tonsils and adenoids, can be something about, like I said, the nasal clearance, which is a huge one. I didn't even mention myofunctional therapy. My hygienist, who's a myofunctional therapist, would be hitting me up against the hand. Those are things that can also be huge in really starting to look at what the issue is, but then actual getting the tongue, the jaws, that movement that's needed to actually support healthy breathing and healthy airway. Um, I feel like many parents don't feel that the surgical risk of an adenoid tonsillectomy outweigh a diagnosis of mild sleep disordered breathing, and it's challenging as just a dental professional be taken seriously about all the positive growth and lifelong health benefits. Do you have scripting that has been beneficial for your patient and families? I do. I do. I'm happy to share. Um, I'm with you. I and interestingly, the hard part about it was when I opened my practice about 15 years ago, I was asking questions about airway, but I wasn't asking as deeply as I am right now. And so some of those patients that started with me that were clearly red flag kids, when they have come in into that where I'm really asking questions, parents are like, well, what's going on here? Like, is this the new trend, And I'm like, nope, the more you know, the more you know, the more you grow. I've had, issues of my own with my own kid. And I really just start talking about, I do share some of my own personal things because that kid that you saw on the picture, Nicholas, it was a big struggle, healthcare system wise to even get a sleep study. And that took 2 years. And once we got it, we literally went to surgery the next day because it was that bad. And so, um, you can use the example of, I have colleagues who've had kids where this changed life and it absolutely changed the trajectory of my son's life. But I'm happy to share some scripting too for you. Next question is curious if you can talk about the oral appliances you recommend for sleep disordered breathing. So and that's actually the question following that too. So there are like I keep my armamentarium full. So I don't go to one particular appliance, but I've used from tooth pillow to Vivos to Myo Brace to the Myo Munchie to Invisalign First to traditional expansion. It really like all those appliances. And some of them because of I like the ortho side of it. And I think that's touting to my residency program. That I even may create a device that may be doing some of the things that I needed to do. So it really depends on what you're trying to do and what your goals are for the appliances that may be used. In adults, some of those appliances require surgery. And so the list can be long or short. I try to keep an open mind about types of appliances because they're changing so much and some are improving so much. And again, in certain cases, I can use one over the other. But I'm happy to also send you, kind of a list of the ones that I use too. I have many parents asking why my child grinds during the day or night. Is this related to what you discussed? The answer is possibly. And so, what I veer from as I'm teaching my associates about how to have those conversations with parents is, I have a concern about your child grinding. And it could be that there may be sleep hygiene. There are a few reasons, I say there are a few reasons why kids may grind. It may be sleep hygiene. Does your child, on electronics, do you have a routine for them to fall asleep? Because they could be just unwinding their day, right? They could be just doing that. Or it could be that this is a sign that they're not breathing as well as they should be. Have you ever noticed that do you hear snoring? Do they have a hard time going to sleep? Do they wake up frequently at night and go back to sleep? Like you start looking, and that's why I used my little sleep disorder breathing sheet because then I can look and I start pairing red flags. And so sometimes I'm like, ooh, this kid may just be, really having a tough time emotionally, and there's some things that are going on that we need to, maybe send to my colleague, psychologist or psychiatrist, or maybe this is my zone. This is airway right here, and we need to talk a little bit about what's happening and really dig down. I will also ask parents to, because some are like, I try not to go in their room because they're asleep and I don't want to bother them. If you can record your child sleeping so I can see what position they're in, right? If they're neck up, laying down, neck up in a weird, position or all over the place and they're sleeping, they may be trying to posture themselves to breathe better at night. And so some of those things I can see. I also ask them to take, when I send the child to say maybe ENT, or send them back to their pediatrician, again, I will say, can you take a video with you? Because it's really, I mean, it's hard to just say, oh, this is what's going on, or, oh, I don't know. Like, we as parents, I think we're pretty good historians, but, sometimes we're not able to share, like, we're not able to really put all the pieces together that we may be doing. And so I'm like, just take a video and send it over, bring it with you to the ENT visit so they can hear and see what's happening with the child. And then day grinding is a lot different from night grinding also. Day grinding sometimes is more neurological. I got through all the questions. Those were fabulous questions. Thank you so much. I see the time is now 9:01. And for those of you that are still on, I appreciate you staying on. Again, I'm here if you need anything. And I'm going to close the session tonight for the Age 1 Advantage. Happy Children's Dental Health Month, everyone.